Hi everyone, I am Dr. Sakshi Arora Hans, your OBGY faculty at Marrow, and today I am here to discuss with you the OBGY recall questions of INI-CET November 2023. With INI-CET May 2024 coming up, these questions become very important. Not only do these questions hold importance, but the topics from where these questions were asked are also very important for you. Now, if you ask me how was the Obs and Gynae paper or how were the Obs and Gynae questions in INI-CET November 2023, I would say the difficulty level was moderate. Questions were asked from the topics, the usual topics, but some of the, the so-called topics where we are very sure that questions would be asked from those topics, they were not asked. And the questions which were asked were slightly tricky. So let's get going and discuss all the questions which were asked in INI-CET November 2023 in OBGY. Right? So number one question here is a clinical question, which is a 34-year-old woman at 30 weeks of gestation presents with complaint of bleeding PV and pain in abdomen. Now, the moment I see that the patient is 30 weeks plus she has come to me with bleeding PV and pain in abdomen, what am I thinking about? I am thinking about antepartum hemorrhage. And which kind of antepartum hemorrhage am I thinking about? Most likely, I am thinking about abruptio because pain in abdomen is seen in abruptio. Okay, let's see what the question is saying further. She says her clothes are drenched and she experienced decreased fetal movements. On examination, her cervix is 6 centimeters dilated, 50% effaced. Now, we all know that whenever there is abruptio, thromboplastin is released, and it is this thromboplastin which makes the patient go into labor, right? So that is what has exactly happened over here. Now, the further question says a BP is 150 by 100. That means PIH is present. All of you know that PIH is one of the very important risk factors for abruptio. Right? Now, on per abdominal examination, her uterus, the size of the uterus corresponded to 34 weeks. Now, patient is 30 weeks pregnant and 34 weeks uterus. That means this is a concealed variety of abruptio. And gradually, my diagnosis is coming to a conclusion that yes, what I thought at the first instance, this is what the patient is having. She has tense, tender uterus, again something which reconfirms that yes, I am dealing with abruptio. No fetal heart sounds were heard. Her urine protein is 2+ and there is no active bleeding. What is the ideal management? Now, please understand, whenever a patient comes to you with abruptio, so this is a case of abruptio. And which variety? Concealed variety, right? Now, whenever a patient comes to you with abruptio, first of all, you have to see whether the vitals of the mother are stable or unstable, whether fetal distress is present or not, and whether DIC is present or not. If any of these three is yes, if vitals are unstable, if DIC is present, or if there is fetal distress, then I don't have to think any further. I have to go for a cesarean section. Now, if suppose the question says that fetal heart sounds are not heard and we are presuming that there is fetal death. Now, if there is fetal death, again, you should see these things. Whether the vitals of the mother are unstable, vitals of the mother if they are unstable, or if DIC is present. Again, I'm going to go for cesarean section in spite of the fact that the fetal heart sounds are not heard and I'm suspecting fetal death. But if vitals of the patient are stable, right, and if DIC is absent, then I am going to go for induction of labor. Now, again, please understand, in this patient, your patient is already in labor, right? She's 6 centimeters dilated. Now, since she is 6 centimeters dilated, what am I going to do? I am going to do ARM. ARM has a very important role in abruptio. What is that role of ARM in abruptio? Number one, when you do ARM, it helps in controlling the bleeding. Number two, it helps in making your diagnosis confirmed because you are going to see blood-stained amniotic fluid. And number three, ARM is also going to act as a method to augment labor. Right? So these are three uses of ARM. Whenever a patient comes to you with abruptio and you are planning a vaginal delivery, please go ahead with ARM. That should be your first step if you are planning a vaginal delivery. Now, if your patient's vitals are stable, if fetal heart sounds are normal and there is no DIC, in that case, you have to look for gestational age. If gestational age is less than 34 weeks, go for conservative management. Right? And if it is more than equal to 34 weeks, go for induction of labor. So that is how a patient of abruptio has to be managed. And in this case, because patient has got high BP, her BP is 150 by 100. Now, according to ACOG guidelines, antihypertensives should be started when BP of the patient is more than equal to 160 by 110. NICE guidelines say that if there is persistent increase in BP of more than equal to 150 by 100, then you can start antihypertensives. So yes, antihypertensives can be started at 150 by 100 and no one is going to question you because you would be following NICE guidelines, right? So I am going to give her antihypertensives and I am going to go for artificial rupture of membranes, right? That is the answer over here, right? Okay. Next question. A 20-year-old female, she visits the OPD with complaints of irregular menses since menarche, increased facial hair. Her BMI is 29 kg per meter square. Ferriman-Galway score was 6 and testosterone level 0.36 nanograms per ml. Her mother is diabetic. She should be advised the following except. This word except is important. Now, first of all, I want all of you to understand that patient has come to you with irregular menses and there is increased facial hair, which means that if we are thinking about PCOS, our two criteria are getting fulfilled. According to the Rotterdam criteria, either patient should be having hyperandrogenemia or hyperandrogenism. Hyperandrogenemia means the clinical features of excessive facial hair, and hyperandrogenism means clinical features of hirsutism, clinical features of excessive testosterone, and hyperandrogenemia means that in blood the levels of androgens are high. So either it has to be hyperandrogenism, that is hirsutism, or it has to be hyperandrogenemia, that is increased levels of androgens in blood. Now in this case, the blood levels which are given to you for testosterone are 0.36 nanograms per ml. Per ml means 36 nanograms per dl. And normally we say that if it is less than 70 nanograms per dl, it is normal. Right? Normally the testosterone levels in a female are less than 70 nanograms per dl. But please understand that again, I would still say that probably this patient has PCOS because anyways, my two criteria are getting fulfilled, irregular menses and she's having your increased facial hair. Right now, if you talk about increased facial hair, then the Ferriman-Galway score is 6. Now, you have been taught in your notes that if Ferriman-Galway score is more than equal to 8, then that indicates hirsutism. Now, if you look at the exact literature, what literature and what up-to-date has to say about Ferriman-Galway score, please remember, we are using the modified Ferriman-Galway score. In modified Ferriman-Galway score, we are going to look at 9 sites and we are going to grade them from 0 to 4. Now, the biggest problem with Ferriman-Galway score is that you have to interpret the score in different populations in a different manner. For example, if you have a black or a white woman, then a Ferriman-Galway score of more than 8 is indicating hirsutism, and that is what we teach in class because that is what our textbooks say. Right? All of them have been written by foreign authors and they say more than 8 indicates hirsutism. Then up-to-date further says that for Mediterranean, Hispanic and Middle Eastern females, Ferriman-Galway score of more than 9 to 10 is considered as abnormal. And for Asian females, it is more than equal to 2, which qualifies as hirsutism. So yes, a Ferriman-Galway score of 6, again, I'm taking it that it is somehow signifying hirsutism to me, right? So yes, hirsutism is present in that female. Now suppose even if I don't talk about PCOS and I'm talking only about hirsutism, that she has increased facial hair, her androgen levels are although normal, but her Ferriman-Galway score is 6. any case, I have to treat her hirsutism. And in order to treat her hirsutism, what is the drug of choice? Drug of choice is OCPs. So yes, I have to give OCPs. Then I'm seeing that her BMI is 29 kg per meter square. That is, she is coming in overweight categories. Then I have to ask her to go for lifestyle modification. And I'm seeing that her mother is also diabetic. She is obese. So I have to tell her that yes, you are at a risk of metabolic X syndrome. Now, am I going to give her only OCPs, or I can add OCPs and androgens? Please understand, this is something which I want to tell you, that the hair follicle cycle, that is of 6 months. The half-life of hair follicle is 6 months. Now, if you have started a treatment for her, which in this case, I am starting the treatment in her is OCPs. Now, unless and until I give OCPs for 6 months, before that, I'm not going to add anti-androgens, right? The drug of choice for hirsutism is OCPs. Now, this OCP has to be used for at least 6 months. And after that, you have to give OCPs plus anti-androgens, that is spironolactone. Other anti-androgens which you can use are flutamide, finasteride, ketoconazole. And then the drug which is used as a last resort is continuous GnRH. Now, you can also use topical creams, eflornithine. All that is right, but you are going to use it only after you have tried OCPs for at least 6 months. See over here what's written. No significant reduction in hair growth may occur up to 6 months. This is a screenshot which I have taken from the best book. Like you have Harrison for medicine, we have Leon Spiroff for gynae and endocrinology. So this is a direct screenshot which is taken from the latest edition of Leon Spiroff. No significant reduction in hair growth may occur for up to 6 months, which approximates the half-life of hair follicle growth cycle. After 6 months, a change in dose or drug or addition of a second drug should be considered if patient judges her response is inadequate. So before 6 months, I'm not going to even add a second drug. In general, treatment once initiated should be continued indefinitely or until the time the patient is ready to pursue fertility, because the problem of hair excess rarely goes away and almost recurs following treatment discontinuation. Clear to all of you? So please remember over here, in INI-CET, we are going to have OCPs and anti-androgens. Now, one more thing I want to ask you. When I have started the treatment, right? Am I going to monitor her serum testosterone levels serially? Am I going to do that? No. This is what, again, the book has to say. Serial measurements of serum androgen levels during treatment are neither necessary nor helpful. Right? However, repeated hormonal evaluation is indicated when hirsutism progresses despite treatment. So if hirsutism is not progressing, till that time I don't want to do a serial measurement of serum testosterone levels. Clear to all of you? Now, my next question to you. Suppose you get a question this time on hirsutism and they say that a female patient comes to you with hirsutism. What is the next step? Now, whenever a young girl comes to you with hirsutism, next step always is serum testosterone levels. If serum testosterone levels are normal and your patient is having hirsutism, for example, in this case, even if we are talking that this is not a case of PCOS, I would consider it as idiopathic hirsutism. Right? And again, hirsutism has to be managed in the manner which I told you, right? Then if the serum testosterone levels are increased, but they are less than 200 nanograms, then you should be thinking about PCOS and you should be thinking about late onset congenital adrenal hyperplasia. In order to differentiate between PCOS and late onset congenital adrenal hyperplasia, you have to check 17-hydroxyprogesterone levels. If 17-hydroxyprogesterone levels are less than 200, that rules out late onset congenital adrenal hyperplasia. If 17-hydroxyprogesterone levels are more than 800, that confirms late onset congenital adrenal hyperplasia. And if they are between 200 to 800, you have to do the diagnostic test, which is ACTH stimulation test. Please remember, in all patients of PCOS, once we apply the Rotterdam criteria, we do not come to a definite diagnosis of PCOS. At that time, we have a differential diagnosis of PCOS, and we are saying that one of the other differential diagnoses is late onset congenital adrenal hyperplasia. So always, as a rule, in patients of PCOS, you should get 17-hydroxyprogesterone levels done to rule out late onset congenital adrenal hyperplasia. Now, if serum testosterone levels are more than equal to 200 nanograms, then you should suspect androgen secreting ovarian tumors. Now, whenever serum testosterone levels are high, then you should always get DHEA sulfate levels done and 17-hydroxyprogesterone levels done, because 17-hydroxyprogesterone will help you to differentiate that whether it is a case of late onset CAH or not, and DHEA sulfate will help you in knowing that if it is an androgen secreting tumor, whether it is an ovarian tumor or an adrenal tumor, because DHEA sulfate is exclusively secreted by adrenals. So if along with testosterone DHEA sulfate levels are high, that means you are dealing with androgen secreting adrenal gland tumor. Clear to all of you? Right. Coming to the next question. Next question is, which of the following is not required to be a consent for the surgery in a patient whose obstetrical score is G6L1A3 with history of 2 previous LSCS? Now, please understand. When there is previous history of LSCS, there are high chances that your patient is going to have placenta accreta spectrum. Placenta accreta spectrum, there are 2 very important risk factors. One is in present pregnancy if there is placenta previa. Number 2 is if there is previous history of cesarean sections, and as the number of cesarean sections increase, chances of placenta accreta spectrum also increase. Now they are asking you that for what thing you are not going to take a consent when you are operating on a previous 2 LSCS patient. Now, option A, risk of bladder injury during surgery due to PAS, which is placenta accreta spectrum. Risk of bowel injury during surgery due to PAS. Possible need for hysterectomy and possible need for blood transfusion. Now, common sense tells me if there is a placenta accreta spectrum, this means that the placenta is unable to separate from the uterus. If the placenta is unable to separate from the uterus, the patient is going to have intractable PPH, and I know that is going to happen. So I am going to take consent for blood transfusion. Number 2, no matter how much you try to separate the placenta, in case of placenta accreta spectrum, you cannot separate the placenta. So you have to do hysterectomy in case of placenta accreta spectrum. So you will take a consent for hysterectomy. Now comes, what all other complications do I expect with placenta accreta spectrum? Now, please understand, when we are using this term placenta accreta spectrum, we are including all 3 types of placentas, that is placenta accreta, increta and percreta. What is placenta accreta? When the chorionic villi are superficially attached to myometrium. What is increta? When they invade the myometrium. And what is percreta? When the chorionic villi are attached to the serosa. Now, when chorionic villi are attached to the serosa vita, there are high chances that there is going to be adhesion, right, between the bladder and between the uterus, and there are going to be adhesions between bowel and uterus. Are you understanding this? Now, if there is a placenta accreta spectrum and there is adhesion and I am doing surgery, there are high chances that I will be injuring the bladder and there are high chances that I will be injuring the bowel. So if you ask me, all these 4 options are correct, right? But since I have to rule out one option, please remember, placenta accreta spectrum may most of the times, placenta is an anterior placenta, right? A posterior placenta is less common, and that is why bowel injury is less common in comparison to bladder injury. Now, so much so that whenever we have to make a diagnosis of placenta accreta spectrum, there are 3 features which tell you on ultrasound that there is placenta accreta spectrum. Number 1, you get placental lakes or you get moth-like appearance, right? That is one feature. Number 2, you get a hypoechoic area behind the placenta which represents decidua basalis. So there is loss of that hypoechoic area. Normally behind the placenta you get a grey area or a hypoechoic area which represents decidua basalis. In case of placenta accreta, there are 2 pathologies. Placenta accreta happens because of 2 reasons. Number 1, there is absence of a Nita-Bucks layer. This Nita-Buck layer was the one which was telling the blastocyst that this is your limit of penetration. You cannot go beyond it. Now, whenever there is a placenta accreta spectrum, Nita-Buck's layer is absent. So, blastocyst goes deeper and deeper inside the endometrium, inside the decidua, and that is why chorionic villi, instead of attaching to the decidua, are attached either to the myometrium or they go and attach to the serosa. A second problem which is happening in case of placenta accreta spectrum is that decidua basalis is absent or defective. Right, and this is the decidua basalis which is appearing normally, which appears on ultrasound as a hypoechoic area behind the placenta. Now, because decidua basalis is absent, so that hypoechoic area behind the placenta is absent. As simple as that. Number three ultrasound feature is that this vesico-uterine pouch, right? So this is the interface between bladder and uterine serosa. It appears as a white line. So this is there is on ultrasound a white line is present between bladder and uterine serosa right, which actually represents the peritoneal reflection. Now, what happens in placenta percreta, because the chorionic villi are invading the uterine serosa, so this white line, which was appearing as a continuous white line between bladder and uterine serosa, now this is interrupted line, right? So why I'm telling you this is that bladder is, in case of placenta percreta, bladder comes very, very close to the uterus and it gets adhered to the uterus. So whenever I am doing surgery, there are high chances that when I'm doing cesarean section, with the bladder adhered onto the lower uterine segment, there are high chances that I may injure it, right? So see over here. There is disruption of a continuous white line reflecting bladder-uterine serosa interface. So this is a typical feature of placenta percreta. So now if I have to choose that will bladder injury happen? Yes, high chances of bladder injury. Bowel injury happens, but the chances are less. That is why I am going to rule out risk of bowel injury. I will not take a consent for bowel injury. I start taking consent for so many things. In case of placenta accreta spectrum, take consent for bladder injury. If there is previous to cesarean section, take consent for hysterectomy, take consent for blood transfusion. I want all of you to know that High Risk Pregnancy, David James, which is one book higher than Williams, says that the complications of surgery on placenta accreta spectrum are, so I'm reading this paragraph for you. Upon establishing the diagnosis, the team should clearly discuss the treatment options and potential complications with the patient and document all counseling in detail. Patient should be apprised of the increased risk of maternal death, the almost certain risk for blood transfusion, likelihood of hysterectomy. So all this can happen. You have to take consent for hysterectomy. In 10% cases, unilateral oophorectomy is required. Unilateral oophorectomy, right? Due to persistent bleeding. Patient should also understand the increased risk of organ damage. Organ damage can happen due to hypotension. Due to hypotension, there is a risk of renal damage and cerebral damage. And then there is increased bowel, bladder and ureteric injury. Increased risk of bladder, bowel and ureteric injury. Then iatrogenic complications and infection and thromboembolism. So there is increased risk of thromboembolism and infection. All these things are very common whenever you are operating a patient in a case of placenta accreta spectrum, right? Now, as I told you, always it's the anterior placenta accreta spectrum which is more common than posterior placenta accreta. So again, I am ruling out the bowel injury over here. Clear? Next question. A 28-year-old primary gravida with low-risk pregnancy presents at 39 weeks 6 days with labor pains. Vital stable. On pervaginal examination, she is 3 centimeters dilated, 60% effaced. Fetal head is at -3 station and membranes are felt as bag of worms beneath the head. What is this bag of worms? This bag of worms is actually the cord which is being felt. And where is the cord being felt? Cord is being felt beneath the head and inside the membranes. So whenever you have, please understand that there are three terms. One is cord prolapse. Cord prolapse means that the membranes are ruptured and your cord is present beyond the presenting part, and it is present beyond the internal os. So it is not just beyond the presenting part, it is also beyond the internal os, right? It is hanging out beyond the internal os. Then comes your cord presentation. Cord presentation means that the membranes are intact and this cord is present beyond the presenting part. It has not yet come out of the internal os. And then we have a compound presentation. Compound presentation means both cord and the presenting part of the fetus, they are present alongside each other above the internal os. So we have cord prolapse, cord presentation and compound presentation. So this over here, what they have said, that a cord is felt like a bag of worms beyond the beneath the fetal head. That means this is cord presentation. Now in cord presentation, you tell me the head of the baby is at -3 station. And if I say I'm going to rupture the membranes, what is going to happen? Head of the baby is up. The moment I rupture the membranes, cord presentation will get converted into cord prolapse. There will be fetal distress and eventually that can lead to fetal death. So common sense tells me I am not going to progress with labor. I'm not going to go ahead with rupture of membranes. I am going to go for emergency cesarean section. Right? Clear to all of you? Yes? Now, how do you manage a case of cord prolapse? Whenever there is a case of cord prolapse, if the cord is lying outside the vagina, then you should try to place the cord inside the vagina with minimal handling. Right? So take a cord, your sponge holding forceps, take a sponge or a gauze piece, wrap it around the cord and gradually, without touching the cord, with the help of sponge holding forceps, put the cord inside the vagina. Please remember, I'm saying place the cord inside the vagina. I'm not saying place the cord inside the uterus. So if the cord is inside the vagina, you are not going to attempt to place it inside the uterus. You just have to place it inside the vagina. Now, then you have to see what is the dilatation of the cervix, and simultaneously you have to lift the pressure of the cord. So because I want to lift the pressure of the cord, I can do 2 to 3 things. Number one, I can do a retrograde filling of the bladder with 500 ml of normal saline, or I can change the position of the mother, which ideally I should be doing first. Rather than retrograde filling, I should be changing the position of the mother to Trendelenburg position or knee chest position, and I should be stopping the oxytocin. Right? Now, once I have done all this, then I have to see whether the fetus is alive or not. If fetus is alive and the cervix is fully dilated, I'm going to do vaginal delivery unless and until where the fetus is in transverse line. Now, if cervix is not fully dilated, then in that case, I'm going to give tocolytics and I am going to do a cesarean section. Now, if the fetus is dead, I prefer a vaginal delivery unless and until it's a transverse lie which has resulted in cord prolapse. So this is how you manage a case of cord prolapse. Which of the following are responsible for increased blood volume during pregnancy? Now, all of you know that during pregnancy, there is fluid and water retention, salt and water retention. So this increased fluid retention, yes, you are going to say that there is increased fluid retention. And number 2, I told you in your OBS physio class, that is maternal adaptations in pregnancy, I told you this, that pregnancy is a progesterone predominant condition. And because pregnancy is a progesterone predominant condition, most of the events which are happening in pregnancy are because of progesterone. But there are certain exceptions where those events are happening because of estrogen and not because of progesterone. What are those events? For example, skin changes, right? For skin changes like chloasma, like linea nigra, which hormone is responsible? Estrogen. For salt and water retention? Estrogen. For obstetrical cholestasis? Estrogen. For increased thyroid binding globulin? Estrogen. And for onset of labor? Estrogen. So all this is happening because of estrogen. So yes, the answer over here has to be action of estrogen and aldosterone and increased fluid retention. That is both A and B. Estrogen is responsible for salt and water retention during pregnancy, right? Which of the following vessels will serve as an alternate source of blood supply to prevent uterine ischemia in case of primary arteries ligated in event of PPH? Now, all of you know that the first artery which you have to ligate in case of PPH is a uterine artery, right? This should be followed by ovarian artery, and then it has to be anterior division of internal iliac artery. Right? Now they are saying is that you have ligated the uterine artery. Now, what will be the alternate source of blood supply to the uterus to prevent ischemia? So, alternate source is going to be ovarian artery. Right? Uterine artery has been ligated. Now, if you remember, I have told you this, that uterine artery gives branches, and from outside to inside, they are ARBS, where A stands for arcuate artery, R for radial artery. Radial artery ki branches are basal artery and spiral artery. Right? So, this means that arcuate artery is a branch of uterine artery, so that is also ruled out. Then round ligament artery is another branch of uterine artery. Uterine artery gives branch to cervix, uterine artery gives branch to a ureter, and it also gives branch to round ligament. The artery the branch of uterine artery which supplies the round ligament is Sampson artery. Right, so answer to this question is ovarian artery. That was a very simple one. Next question. A 28-year-old multigravida comes to emergency at night with inversion of uterus following delivery of the baby. When the nurse waited till delivery of the placenta, her BP is 110/70, pulse rate 90. What should be the management in this case? Right? Option A, manually remove the placenta, then reposition the uterus. Option B, start oxytocin. Option C, reposition the uterus without removing the placenta. Option D, shift the patient to OT and reposition the uterus under anesthesia. Now, I have told you all that uterine inversion is an emergency, and you have to manage uterine inversion in the stepwise management, which I have told you in Marrow, which I have written in One Touch, and I have told during my classes, offline classes as well. So, management of uterine inversion, first of all, this is an emergency. So, you have to call for help and you have to resuscitate the mother. After that, I want to reposition the uterus. But if I am repositioning the uterus with oxytocin drip on, will I be able to reposition? No. So, I am going to stop the oxytocin, number one. Number two, am I going to remove the placenta or not? See, beta, if you remove the placenta while the uterus is lying outside the body, do you think uterus will contract and the bleeding will stop? Never ever will that happen. So I am not going to remove the placenta. With the placenta in place, I am going to put uterus back into the body, right? Using manually. This I'm going to do manually, and this is what is called as Johnson's technique, right? Now, if this is first time which I'm going to try, just by stopping the oxytocin drip, I'm going to go for manual replacement of the uterus without removing the placenta. Now, if this fails, then I am going to give uterine relaxant or I am going to give a general anesthesia, and again I'm going to attempt to place the uterus back into its position. Again, if that fails, then I'm going to do surgery. In surgery, I can do Huntington method, which is an abdominal surgery, and if a constriction ring is present, then I have to go for Holtein's method. Nothing do you have to do in surgery. In surgery, you are going to open the abdomen. You are going to see that the uterus is hanging out. So you are going to put 2 Babcocks on the round ligament and pull the uterus up. That is all what you have to do. And that is what is called as Huntington's method. Right? Now, once replacement has been done, now you have to stop the tocolytic, you have to remove the placenta, you have to give oxytocin, and you have to give antibiotics. Please remember the names of outdated surgeries or the outdated methods for uterine inversion are O'Sullivan's hydrostatic method and a surgery which is called as Spinelli surgery, which was a vaginal surgery. Right? So this is what you have to remember, that what am I going to do? Am I going to manually remove the placenta and then reposition the uterus? No. Am I going to start oxytocin? No, I have to stop it. Reposition the uterus without removing the placenta? Yes. Shift the patient to OT and reposition under anesthesia? That's a later step. Right? So answer over here is option C. Please remember, in uterine inversion, it is the fundus of the uterus prolapses. And what is the difference between uterine inversion and prolapse? Right? So I'm going to draw 3 diagrams and I'm going to show this difference to you. So suppose these lines are the supports of the uterus and this over here is the uterus. So these are the supports of the uterus. Now, if the uterus is going to hang down like this, maintaining its anatomy, right? This is what is called as prolapse. And why did this happen? This happened because these ligaments which were supporting the uterus, the muscles which were supporting the uterus became weak. Now, if the fundus of the uterus inverts and then it prolapses, that is what is called as inversion. Now, if you are giving spotters where you are given two images, one of prolapse and the other one of inversion, or just one of them singly, and you have to identify whether it is prolapse or inversion. Can you see over here? In prolapse, the internal os should be visible. In case of inversion, internal os should not be visible. So now I have two spotters here for you. Spotter image A and B. Tell me which one is prolapse and which one is inversion. Image A is inversion. And image B is uterine prolapse. Right? Clear to all of you? Now, about uterine inversion, I want you to know that it is mostly a iatrogenic complication when you pull the cord and the placenta has not yet separated. Ideally, you should be waiting for signs of placenta separation to appear and then you should be putting traction on the cord. All of us know that placenta is removed by control cord traction. What do you do in control cord traction? In control cord traction, with one hand, you are pushing the uterus up and back, and with your other hand, you are giving a steady traction to the cord. Right? Now, suppose I was in a hurry. I did not see that the signs of placental separation are present or not. And without the placenta separating, I have pulled the cord. The moment I pull the cord, the fundus of the uterus inverts and come out, and patient goes into immediate shock. So whenever you get a question that patient goes into immediate shock after delivery, always think about uterine inversion. See, most common cause of shock after delivery is PPH. But in PPH, patient is going to go into shock once she has got excessive bleeding. After excessive bleeding, she's going to go into shock. She will never go into immediate shock after delivery. In uterine inversion, the initial shock which is happening is neurogenic shock. And that is why patient immediately goes into shock after delivery. It is later on that because the fundus of the uterus and the entire uterus is hanging out, the tone of the uterus is lost, and later on patient has hemorrhagic shock. So in uterine inversion, initial shock is neurogenic. This is followed by hemorrhagic shock, and death of the patient is due to hemorrhagic shock, right? Now, the other important thing about uterine inversion is whenever you are going to do a per abdominal examination, you are going to feel a cup-like depression. Where will that cup-like depression be felt? It will be felt just below the umbilicus. Why? Because that is the height of the uterus immediately after delivery. What is the height of the uterus immediately after delivery? It is just below the umbilicus at the level of 20 weeks of pregnant uterus size. So just below the umbilicus, you are going to get a cup-like depression, or you will see the entire uterus hanging out. When you will do a per vaginal examination in uterine inversion, you are going to get bleeding, plus there will be a globular mass inside the vagina. Now, if you get a question that the patient is gone into immediate shock and there is breathlessness, the moment the word breathlessness is added, please change your diagnosis to amniotic fluid embolism. Whenever your question is saying that there is respiratory difficulty and shock after delivery, or breathlessness and shock after delivery, it has to be amniotic fluid embolism. Clear to all of you? Right? Okay. Next question. Which of the following leads to an increased risk for borderline ovarian tumors? Now, if again you are a Marrow subscriber, or if you have read One Touch, or if you have attended my offline classes, I have always told you that there are some estrogen dependent conditions in gynae. And this is something which we've done in gynae physio integration. Right? So the estrogen-dependent conditions in gynae are fibroid, endometriosis, endometrial cancer, ovarian cancer. Right? Now, I have told you that in all these hyperestrogenic conditions, there are certain common risk factors and there are certain common protective factors. Right? What are the common risk factors? Common risk factors for all these conditions is nulliparity. Nulliparity is a common risk factor. Now, obviously, if nulliparity is a risk factor, multiparity and pregnancy, they become protective factors. Then another risk factor is obesity. Why obesity? Because we all know androgens are converted into estrogens in adipose tissue with the help of enzyme aromatase. Yes. So that is why obesity is a common risk factor for all hyperestrogenic conditions. In obese females, more of androgens will get converted into estrogens. So if obesity is a risk factor, physical exercise becomes a protective factor, right? Number 3, early menarche and late menopause. Early menarche and late menopause are common risk factors, right? Obviously, if there is early menarche, a female is getting exposed to estrogen at a younger age. And late menopause means till late age she is exposed to menopause. Please remember, late menopause means if a female has not had menopause. I'll write it properly. Otherwise, you will say, ma'am wrote 75 years. It is more than equal to 55 years. If a female doesn't attain menopause by the age of 55 years, that's a late menopause. And in all late menopause females, you should get an endometrial biopsy done to rule out endometrial cancers, right? Please remember this point, okay? Now, a common protective factor, another common protective factor is smoking. Smoking inhibits the enzyme aromatase, and so it is protective in all these conditions, but that doesn't mean all the girls who are listening to me will start smoking. Don't say that ma'am said it is protective for endometrial cancer, ovarian cancer, fibroid and endometriosis. That means we've got the license to smoke. No, your medicine faculties always tell you why is smoking harmful. So I am not saying that you should start smoking. I'm just telling you the MCQ where they ask you in which all conditions is smoking protective, which includes one more condition of pregnancy, and that is PIH. In all these conditions, smoking is protective. So why I'm telling you this is because suppose if you forget the risk factors for ovarian cancer, you don't remember any of the risk factors for ovarian cancer, you just forgot to revise them. Then you know that ovarian cancer is a hyperestrogenic condition, and all hyperestrogenic conditions are more common in nulliparous females. So which of the following will lead to an increased risk? Low parity. Please remember, OCP intake decreases the risk of ovarian cancers, right? PCOS is plus minus. See, PCOS, there is two things. See, in ovarian cancer, one is excessive estrogen, that is a risk factor for ovarian cancer. The other risk factor for ovarian cancer is excessive ovulation. That is the theory of incessant ovulation. Theory of incessant ovulation says that more a female ovulates, more are chances of ovarian cancer. Right? That is why, please understand, pregnancy is a protective factor. Why? Because during the entire 9 months, patient will not ovulate. Right? So that means there won't be any ovulation, and that means it's protective for ovarian cancer. Similarly, multiparity. Multiparity means multiple times a female has become pregnant. So for those 9 months, there has been an ovulation, right? So that becomes a protective factor. OCPs becomes a protective factor because OCPs bring about an ovulation. Breastfeeding becomes a protective factor for ovarian cancer because of the theory of incessant ovulation. Now, when we talk about PCOS, in PCOS, definitely there is an ovulation. But in PCOS, there are two more problems, rather 2-3 more problems. Number one, PCOS patients are obese. Obesity is a risk factor for ovarian cancer. In obese females, there will be excessive estrogens. So again, that is a risk factor. Number 3, for infertility, we use clomiphene citrate in a patient of PCOS. Clomiphene citrate means you are making a female, that is an ovulation inducing drug, right? So that again becomes a risk factor. That is why PCOS is a controversial risk factor. We don't know whether it is going to cause ovarian cancer or not. It's plus minus, right? So this becomes a plus minus risk factor. Ovarian cyst has nothing to do with ovarian cancer. Functional ovarian cysts don't have any risk for ovarian cancers. So the answer over here was option B. Very, very important that you should remember the risk factors for ovarian cancer. I would want all of you to take a screenshot of this table and revise it for your upcoming INI-CET, right? Then, what do you understand by borderline tumors? Borderline tumors are tumors of low malignant potential. They remain confined to ovary for a very long time. They are seen in younger females, right? So normally the age group for ovarian cancer is 60-70 years. This will be seen between 30 to 50 years. Borderline ovarian tumors will have a good prognosis. So these are few points which I want you to remember about borderline ovarian tumors. But at this time, there were 3 questions from ovarian tumors which were asked. Ovarian cancers was one of the hot topics for INI-CET this time. And this is what they usually do. In INI-CET, 3 questions once were asked from DSDs. Once 3 questions were asked from cancer cervix, and this time it is cancer ovary, right? Now, which of the following is a virilizing tumor of the ovary? Virilizing tumor means androgen secreting tumor of the ovary. Now, let us try to rule out the options and then come to the answer. Carcinoid tumor, is it an androgen secreting tumor? No. Brenner's tumor is an epithelial tumor. Is it an virilizing tumor? Absolutely not. Thecoma, what is thecoma? Thecoma is a stromal tumor of the ovary. So, is it a virilizing tumor? Absolutely not. What is the answer by exclusion? Arenoblastoma. What is arenoblastoma? Arenoblastoma is other name for androblastomas, which is a virilizing tumor of the ovary. Right? So when we are talking about sex cord stromal tumors, we group the sex cord stromal tumors into granulosa stromal cell tumor. That means granulosa cell tumor and stromal tumors. In granulosa cell tumor, we have granulosa cell tumor, which is an estrogen secreting tumor. And we have the thecoma and fibroma group, which will have thecomas, fibromas. Then we have androblastomas, which are virilizing tumors. Androblastomas ka hi second name is arenoblastoma. So, in some of the texts, it's written as androblastoma, some it is written as arenoblastoma. And this category of tumor includes Sertoli cell tumors and Leydig cell tumors. Then we have gynandroblastomas. Gynandroblastoma is a tumor which is secreting both estrogen and androgens. And then please remember that steroidal cell tumors and sex cord tumors, all type of sex cord tumors are included in sex cord stromal tumors. Just remember, steroidal cell tumor is also a part of sex cord stromal tumor. Right? This is one thing which I want you to remember. Then, next question, a 30-year-old nulli gravida is on DMPA and she comes 14 days past her due date for her next DMPA. What should be advised to her? Please, first of all, let's talk a little bit about DMPA. DMPA is nothing but medroxyprogesterone acetate, which has been included in our National Family Program by the name of Antara. Right? What is the dose of DMPA? 150 milligrams, and it has to be repeated after every 3 months. So after every 3 months, patient should come to you for next injection of DMPA, right? Now, these are screenshots from our national family planning guidelines, and I have directly taken a screenshot so that you can read. Now, suppose a patient comes to you at 3 months after the last injection on the scheduled date. So, patient was a very, very committed patient. You told her that she has to come on 5th of April and she is there on 5th of April in front of you that please give me the next injection DMPA. Obviously, I don't have to do anything. I just have to give her DMPA, no backup is required. Now we have defaulters. In defaulters, we have females who are saying that their DMPA had to stop. I mean, they had to re-inject themselves on 5th of April. But since they are going out, they have come to you 2 weeks earlier. So if a patient comes to you 2 weeks earlier or up till 4 weeks later from the scheduled date, this is what is grace period. A patient's injection was due on a particular date. Patient is coming either 2 weeks prior to it or till 4 weeks after that date. Till here, I consider it as a grace period. If a patient is coming to me in this period, again, I am going to give a DMPA without any backup method. Right now, I want you to see, if patient is coming after 1 month, that means 4 months after giving DMPA. So she's coming after 1 month of her last injection. After 1 month of the time when she was told to come. So 3 months is the life of DMPA. Now 1 month was the grace period. Now she is coming after 4 months. She had to get injection on 4th of May. She is 4th of April. She's coming to you on 6th of May or 7th of May. Patient is coming at that time. If she's coming after 4 months total, then you have to rule out pregnancy. If patient is not pregnant, you have to give her DMPA and you have to advise a backup method for 7 days. This is if patient is coming 4 weeks later than her scheduled date. right? If she's coming 4 weeks later than her scheduled date, do a UPT, give her DMPA and advise her a backup for up till 7 days. But if patient is coming to you 2 weeks earlier or within 4 weeks of the scheduled date, you don't have to do any backup. You are not going to do any UPT. That is what Government of India guidelines say. In every patient, in such case, you don't have to do a UPT and you do, but yes, you have to give DMPA. So over here, most of you have answered, ask her to do UPT before taking DMPA. Government of India guideline is saying she is coming to you 14 days past her due date. Am I going to do her UPT? Government of India guideline says no. You have to give her DMPA and no backup required. Now you are not going to believe me, right? Because these are screenshots from Government of India guidelines. Now I am showing you screenshot from Leon Spiroff, which I told you is the best book which we have got on endocrine problems, contraceptives, infertility. Direct screenshot from Leon Spiroff, page 929. When given properly, there's an effective 2-week grace period that allows for late re-injections. A study of women arriving late for re-injections concluded that even a 4-week late re-injection provided equivalent protection against pregnancy. So even if patient is coming to you after 4 weeks, up till 4 weeks or late, it is providing protection against pregnancy. Women who are more than 4 weeks late for re-injection should be tested for pregnancy, re-injected if the test is negative, and advised to use a backup for 7 days. So 100% which the question is saying that she's coming to you 14 days past her due date, I am not going to do a UPT. Is that clear to all of you? What are you going to do? You are going to give her DMPA and no backup method. Clear? These questions are confusing, but you have to remember a few things. Now I am going to tell you same thing. This time it was asked on DMPA. Next time they could ask you about missed pills. They can ask you about POPs. They can ask you about transdermal patch. So let's talk a little bit quickly about them so that you have a clear-cut idea of how you're going to answer questions related to them. So transdermal patch, I'm sure all of you know, that is what is Ortho Evira, and it is a 4.5 centimeter patch. This 4.5 centimeter patch has got ethinyl estradiol 750 micrograms and norelgestromin. What is norelgestromin? Norelgestromin is a metabolite of norgestimate. So it has estrogen and progesterone, right? Now, this patch has to be applied for 1 week. One patch for 1 week, and then on the same day next week, you have to apply another patch, but yes, at a different site, and then another patch in third week. So say it is not like this, like you are a ring. We have these estrogen and progesterone rings also. A single ring is used for 3 weeks. In patch, it is not like that. In patch, the combination is of 3 patches. You are going to get 3 similar patches, and they tell you that we are going to tell our patients that one patch has to be applied every week, right? Now, and then after 3 weeks, there is going to be 1 week off, and during that 1 week off, patient is going to bleed, and whenever she is going to bleed, she will start her next cycle. That means she will apply another patch. Clear to all of you? Now my question to you is, suppose this patient got her patch detached. She went to swimming and the patch got detached. Now, if the patch got detached and within 24 hours, patient has placed the patch, nothing needs to be done. Now, if the patch got detached and there is more than 24 hours have passed, in that case, patient has to stop the current cycle. She has to start a new cycle by applying a new patch, right? And she has to, so that is all what she has to do. She has to attempt reattachment. So she has to start a new cycle. She has to apply a new patch. Okay. Now, this is if more than 24 hours has passed, she is going to start a new cycle. Now I'm saying that this patient, I told her that every Monday you have to apply a new patch for 3 weeks. So after first week, she had to apply her patch next Monday. Now she forgot, right? If she is forgetting to apply the patch in week 1, right? A new patch had to be applied and she forgot to apply that patch in week 1. Then in that case, she should apply the patch as soon as she remembers, and she should use a backup for first week of the new cycle. If she forgets to apply the patch in week 2 or week 3, Then if it is less than 48 hours have passed, then she does not need to use any backup method. She has to apply a new patch immediately and no backup is required. But if she has forgotten for more than 48 hours, then a backup is required for 1 week. So simple, very, very simple. I'm going to make it for you. I am just saying that if your patient is forgetting to apply the patch in first week, you have to give a backup for 1 week, right? 7 days backup is required. In week 2 or 3, a 7-day backup is required only if more than 48 hours have passed, right? So understand it this way. I know this is slightly confusing. Suppose patient had her period and she was on patches and I had told her that the day you have your period, you have to apply a patch, and she forgot. Today she had her period, she forgot and she applied a patch. She remembered it tomorrow or day after tomorrow. In that case, she will have to use a backup for 7 days. Clear? Now my second case is that patient applied the patch on day 1 of her period. That was Monday when she applied a patch. Now she was told that next week, again Monday, you have to change this patch. Next week she forgot to change the patch, right? And less than 48 hours have passed and she remembered, oh, I forgot to change the patch. In that case, no backup required. But if more than 48 hours have passed, then a backup required. Clear to all of you? So remember about patch. Then comes POPs. In POPs, we have mini pill and we have the POP which is available in India, which is INI-CET. INI-CET has got desogestrel. So when you are using the traditional mini pills, they cannot tolerate a gap of more than 3 hours. Right? You have to take the pill daily at the same time. And if a gap of more than equal to 3 hours occurs, then you have to tell a patient to use a backup for 48 hours. But in INI-CET pills are more forgiving. That is what we say. A delay of 12 hours, up till 12 hours is acceptable. If the delay becomes 12 hours or more than 12 hours, then you have to tell the patient to use a backup for 48 hours. Right? This is how you are going to manage in case of mini pill and in case of INI-CET, which is a desogestrel containing mini pill sold in India. Then comes normal pills, OC pills. Again, you have a lot of confusion regarding this and you have to follow Government of India guidelines. Government of India guidelines say that if any time during the cycle, if a female misses 1 or 2 pills, then as soon as she remembers, she should take 1 pill and she should continue her schedule as normal. Right? So if she misses 1 or 2 pills any time of the week, any time of the regime, she can just remember, she can take up that 1 pill and she can continue her regime like she was following. Now, if she misses 3 pills, then you have to see 3 or more pills, that whether these pills are missed in first or second week or whether they are missed in third week. If they are missed in first or second week, initially, yes, she has to take 1 pill as soon as she recalls and then she has to continue the regime. Along with that, she has to use a backup for next 7 days. And in case she had intercourse in the past 72 hours, she has to use an emergency contraception. Right? Now comes if she misses 3 or more pills in third week. If she's missing 3 or more pills in third week, in that case, again, the moment she remembers, she has to take 1 pill and she has to continue her entire pack. Once her entire pack is over, she does not have to wait for 7 days for her periods to come. Right? Immediately, she has to start a new pack next day. Are you understanding? She's not going to give a break. Instead of giving a break, the day her pack gets over, next day she has to begin a new pack. Right? She has to take a backup for 7 days, and if she has had intercourse within 72 hours, she has to use emergency contraception. So the only thing what you have to remember is if 3 or more pills are missed, backup is required for 7 days. Emergency contraception is required. 1 pill has to be taken as soon as she remembers, and then she has to continue her cycle. The only difference is in first and second week, if 3 pills are missed, then she has to continue her regime as normal. If 3 or more pills are missed in 3rd week, she has to continue that pack, and once that pack is over, she does not have to wait for a bleeding to come. From the very next day, she has to start a new pack. Clear to all of you? So this is how you have to deal with missed pills, right? Now, next question. A 67-year-old female is brought to OPD in poor general condition. Her examination showed that she has right ovarian mass. CT indicated peritoneal caking. What do you mean by that? This means that this cancer has now reached to stage 3. Her CA-125 levels are 1200 international units. What would be the management? Now, please understand, whenever we are talking about management of cancer ovary, for staging of cancer ovary, you go for a surgical staging, and in surgical staging, you've already done a TH plus BSO and you have done omentectomy. Now, after you have done this, the pathologist tells you the stage. If stage is early stage, that is stage 1 and stage 2, you have to go for chemotherapy. Now, in stage 1, if it is stage 1A grade 1, like you do in endometrial cancer, if it is stage 1A there, here it is stage 1A grade 1, you don't have to give any post-operative therapy. If it is stage 1A grade 2 or 3, or if it is stage 1B, then in that case, or if it is stage 2, in this case, this has to be followed by chemotherapy, and the chemotherapy which we use is cisplatin and paclitaxel. How many cycles? 3 to 6 cycles. Now, if it is stage 3 and 4, in stage 3 and 4, you will have to go for a debulking surgery, beta. You will not be able to just do a TH and BSO. You will have to remove, because the cancer has spread now into the pelvis, you will have to remove wherever the cancer can be removed. You have to remove it from there. That is, you have to do a debulking surgery. And this has to be followed by chemotherapy 6 to 8 cycles. If debulking surgery cannot be done because there is massive ascites or there is massive pleural effusion, then you have to go for neoadjuvant chemotherapy, where you give 2-3 cycles of neoadjuvant chemotherapy and then you go for debulking surgery. So in this case, what am I going to do? Because it is they are saying peritoneal caking is present, that means the peritoneum is involved, that means it is stage 3. So I am going to go for a debulking surgery followed by chemotherapy. Clear to all of you? Okay. Next question, and the last question for the session, which is a very, very easy one. No, there is one more question. The recombinant form of vaccine to prevent cervical cancer has which of the following proteins? So all of you know, I have taught you that HPV vaccine, it is made from L1 capsid protein, right? E1 and E2, these are proteins which are required for viral replication. And E6 and E7, they are required for malignant transformation. Right? E6 is the one which is going to knock off the P53 gene, and E7 is the one which is going to knock off the retinoblastoma gene. Right? So that was a pretty easy one. And then last is, which of the following viruses has least teratogenic effect? Now, all of you know cytomegalovirus has a teratogenic effect. Rubella, their congenital rubella syndrome. Chickenpox, yes. So the answer of exclusion is herpes simplex virus. Please remember, herpes simplex virus, most commonly it is transmitted in perinatal period. In 85% cases, it is transmitted in perinatal period. So most of the times, whenever there is herpes simplex virus infection, it leads to neonatal infection. In neonatal infection, you get SEM, you get skin lesions, eye involvement and mouth involvement is there, right? And yes, at times, there is also neurological involvement in the neonate. But most of the times, because it is a perinatal transmission which is happening, it affects the neonate. The teratogenic effects are not seen, right? Congenital malformations are less common with HSV. Another virus which does not have any teratogenic effect is HIV. HIV does not have any teratogenic effect at all, right? So this is all what you need to know in Obs and Gynae from the recall. And thank you so much. All the best for all your upcoming exams. And do let me know whether you liked the session or not in the comment section. Take care. Bye.